Violence in healthcare settings occurs so frequently that public health experts now classify it as an endemic hazard. Many professionals come to expect verbal abuse or physical assaults as a routine, unavoidable part of their shifts. Most of these incidents fall into two specific categories. Type 2 violence happens when a patient or client becomes aggressive while receiving care. Type 3 is lateral, meaning it occurs worker on worker, taking the form of bullying, intimidation, or harassment among colleagues. Looking at this policy document, the Occupational Safety and Health Administration's General Duty Clause requires employers to furnish a place of employment completely free from recognized hazards. This creates a strict legal mandate to protect staff from violence. To systematically control this hazard, we use the three-level prevention framework shown in this timeline. It divides the response into three distinct zones: primary prevention in blue, secondary in orange, and tertiary in green. Because an escalation of hostility is a predictable sequence of events, disrupting it requires both the healthcare facility and its clinical staff to execute specific, synchronized actions at every step of this timeline. The blue phase focuses on the time before any hostility surfaces. Primary prevention is entirely proactive, aimed at identifying vulnerabilities in the environment and removing them. For employers, this begins with a thorough worksite analysis. Safety committees comb through OSHA injury logs, workers' compensation data, and staff surveys to pinpoint exactly where the risks are highest. For nurses and staff, primary prevention is rooted in professional standards. As we can see in this section of the ANA Code of Ethics, individuals are required to treat colleagues with dignity, establishing a baseline where incivility cannot take root. The organization then supports this baseline with highly customized training. A behavioral health unit faces different stressors than a pediatric wing, meaning the education must reflect the exact hazards and historical data of that specific department. Ultimately, the primary goal of the blue phase is to build a non-punitive reporting culture. Staff must feel secure pointing out system flaws or reporting near misses without fear of retaliation, allowing the facility to fix vulnerabilities early. When tensions rise and an incident begins, we enter the orange state. Secondary prevention focuses on immediate, real-time strategies to contain the situation and minimize physical or emotional harm. In these moments, a clinician's best defense relies on non-physical intervention skills. By utilizing active situational awareness and practice de-escalation techniques, staff can often calm an agitated patient before the conflict turns physical. This real-time response requires heavy backing from administration. As this prevention documentation outlines, management must involve frontline workers in safety committees that assess, plan, and intervene during these volatile moments. Secondary prevention also addresses worker-on-worker hostility. Instead of immediate formal discipline, facilities deployed tiered, non-confrontational strategies, starting with an informal cup of coffee conversation to address disruptive behavior early, only escalating to strict discipline if the pattern continues. By executing these strategies, the organization proves to its clinical staff that they are protected by an active safety net, ensuring nobody is expected to face high-stress confrontations alone. Once the immediate threat passes, the response shifts to the green state. Tertiary prevention manages the aftermath, focusing on recovery and preventing the same situation from recurring. The first administrative task is creating a detailed written account. Documenting the timeline, individuals, and sequence creates a permanent record. Additionally, Step 3 emphasizes recovery. Affected staff must seek psychological counseling, engage employee assistance programs, and file workers' compensation claims if physical trauma occurred. The employer must support this recovery by immediately relieving the affected nurse of their duties. This provides the necessary time to speak with law enforcement, receive medical care, and begin processing the event. While the individual recovers, the facility's safety committee conducts a root cause analysis. The focus remains entirely on identifying structural or process weaknesses that allowed the violence to occur, actively avoiding any blame directed at the staff. The green phase acts as a vital intelligence gathering mechanism. Data from the incident report and root cause analysis feeds directly back into the blue phase, updating policies and training to patch the newly discovered vulnerabilities. As we map these stages onto this matrix, we see how the framework operates. At every point, before, during, and after an event, there are distinct overlapping actions required from both the employer and the employee. Without this structured support, Persistent exposure to incivility and aggression leads directly to emotional exhaustion, forcing highly qualified clinicians to experience burnout and abandon the profession. While healthcare organizations hold the legal responsibility to furnish a hazard-free workplace, sustaining a true culture of safety demands the continuous vigilance of every person on the floor. By implementing this three-tiered approach, clinical teams step into their shifts with confidence, knowing their safety is supported by a robust shared system.